Welcome to the Next Step in Care learning series. This video is designed to provide healthcare and social service providers with ideas and guidance on ways to work together with family caregivers.
We are told to celebrate cultural diversity. See banners that say celebrate cultural diversity. Cultural diversity, I also looked up, and it just said it's about celebrating the differences between people that are based on culture. But we have to be careful about celebrating these differences based on culture, but not on race. But sometimes race and culture go together. Okay? And it can be difficult, and you have to be really wide awake to be sorting out those differences in your head. What's happening when I sit down with an African-American family at Bronx Lebanon and a palliative care consult has been called? Okay, and you'll notice that I said African-American, I didn't say black. Black, to me, is anybody that we can look at and identify a specific group of people. These are people of African descent who are Americans who have lived their whole lives in America. There are black people from the Caribbean, there are black people from South America, from Africa, of all different kinds of cultures. So there are Muslim people who are African from West Africa who have a set of rules that are based on being Muslim that might be part of what we think of when we think of cultural diversity. For African American people, I have learned, okay, there is a high percentage of African American people have Christian religious affiliation and are serious about their Christian religious views. I'm up to 11 minutes, I have 4 to go. Okay, there is a tradition of shared decision-making in extended African-American families. So I see this at Bronx Lebanon all the time. I see second and third cousins and grandparents and relatives coming from all over the country coming in to participate. You know, sort of, as a white guy, I think of the nuclear family of mother, father, husband, wife making decisions, but in African-American families, it's such a much more sort of democratic decision-making process in big families. And there is not least among African-American people, there is the legacy of racism. There is a legacy of racism both in society and a legacy of racism that is ongoing in medicine in terms of how that will influence people's attitudes to what I have to say about palliative care. Okay? Dick Gregory, the famous black comedian, said, now we're supposed to embrace death. That's what's being asked of us. After all of this, now we're supposed to embrace death. There was a study that came out just recently that said that doctors, shown pictures of white patients and black patients, and given the exact same clinical scenario, did less of a cardiac workup on the black patients than the white patients. Okay? These weren't doctors who, if you asked them, would say, I hate black people. Okay? Again, it's these unconscious attitudes that are operating. And by the way, the only doctors who didn't do a different workup were black doctors. However, I heard on NPR, which is where I get most of my medical information these days, just the other day, a study that showed that both black restaurant patrons and white restaurant patrons are likely to tip black wait staff less than white wait staff. So this sort of brings up the idea that racism isn't just about people in other ethnic groups, it's about people in your own ethnic group. And it's not necessarily about positive attitudes, it can also be about negative attitudes. So when I sit down with an African American family, there's a lot going on, even before we get to what Jane said. Not least of which might be my need to be aware not only of my attitudes towards who they might be based on race, and the way I responded to that happening in the coffee shop was to say to myself, I can't let that happen again. When I see someone, I have to think about who that person is, not just click into an unconscious set of assumptions. However, I know that those people might be looking at me and thinking, what scam does this white man have for us today? And it's reasonable for them to think that because that's what has happened through history, and that's what continues to happen. And by the way, maybe there's Christian religious affiliation, and maybe there's a tradition of shared decision-making, and maybe these are these sort of real and acceptable cultural issues, in addition to sort of the racial kinds of attitudes. But I have to tell you, when I sit down at the desk, and I'm sitting across from a gentleman who's African American, he's a unique individual. Populations may have characteristics. Each person, to me, I have learned, I'm going to deal with one-on-one. Maybe he's Christian, maybe he's an atheist. Maybe he cares about what his cousin from Georgia thinks, and maybe he doesn't. And I have to have that consciously in my head when I'm dealing with that person. So how do we, myself and these families, how do we overcome this? And you know, it's funny because I have 20 seconds to go, and I can tell you that it's really pretty easy.
I think you could take a few more minutes. Really.
You know, this paper that I wrote about the effects of palliative medicine consultation on DNR status in African Americans, what this paper really said was, if you look at the literature, African American and Latino and other minority groups in this country, not necessarily minority groups in New York, where I think I'm in the minority, but minority groups in America, will elect more aggressive care and less hospice and less often agree to DNR than comparable case-controlled white people. Okay? And there's reasons. There is the legacy of, you know, undertreatment, of having difficulty accessing good care. Why would somebody agree to DNR when the reason that they have stage 4 cancer is because they couldn't get good care to start with? However, I have to tell you that there's no big secret here. Okay? When I sit down with the family, what I am going to convey to them is true, and it is that I actually care about what becomes of them as patients or what becomes of their loved ones. I know about what Jane is talking about in terms of the issues that people want in the palliative care consultation, and I know that people want to avoid suffering, and I know that people want to avoid unnecessarily prolonging the process of dying, etc. And I know that there's going to be a subsegment of people who in fact will want to be coded, and will want to be in the ICU, and will want to be kept alive no matter what. Our job as palliative medicine practitioners is to give them their options and let them make the choices without putting our own sort of values into it. But what I can tell you is that people who start out sort of sitting in a little alcove next to the ICU, kind of like this, by the end of a half-an-hour conversation, when it becomes apparent that we in fact are individuals dealing with each other in a very difficult situation, and when our individuality breaks through these sort of superficial and unconscious and subtle attitudes about race, that at the end people are like this. And I know their name, and they know my name, and we're able to get to what needs to be done for that patient. So having sort of said all this stuff about race, I'm going to finish this by saying that what really matters is the relationship. All this stuff needs to be kept in mind. We have to be conscious. We have to be aware of what we're thinking so that we can get beyond those attitudes. But having done that, what really matters is relationship. And if you are sincere, and if you mean what you do, and if you do what you do well, you'll form a relationship with people incredibly quickly. And how you move forward will be based on that relationship and not based on those sort of superficialities.